Okay, hi everybody. Welcome to the iPANEL webinar for August 11th, 2015. Today our presenter is Ibolya, and she is going to talk to us today about rural nurses' self-perceived competence in addressing spiritual needs using a palliative approach. Ibolya has worked for the Northern Health Authority as a primary health care developer, primarily in mental health and addictions, in Fort St. John in northern BC since 2003. Prior to moving to Canada in 2002, she studied psychiatric nursing at Homerton College in Cambridge, UK, and has a Bachelor of Arts degree in social work from University of West, and I apologize if I mispronounce this, Timisoara, Romania.
Yeah.
Okay. So, Ibolya, if you would like to start, and feel free to say a little bit more about yourself.
Absolutely. I will add that I obtained my master's degree in science of nursing from Trinity Western University, and my presentation today is based on my research for that degree. So thank you everyone for coming, and those who will be listening later wanting to be interested in the rural northern nurses' self-perceived competencies in addressing the spiritual needs of patients with life-limiting conditions by using a palliative approach. It's a mouthful, but what I'm hoping today is to kind of make it more simple and focus on the concepts for the first part of the presentation. And the next part, I will be focusing on the particular research that happened in Northern Health. So just a brief introduction that we do at every webinar. What is iPANEL? What is iPANEL about? So you can read here that it's Initiative for a Palliative Approach in Nursing, Evidence and Leadership. It's co-led by Dr. Stajudar and Caroline Taylor. And what is looking at as a research question is how and in which context can a palliative approach better meet the needs of people with chronic life-limiting conditions and their families, and guide the development of innovation in healthcare in British Columbia. This is a definition of the palliative approach. I'm not going to spend time on reading this because it's one of my major concepts in the presentation, so I'll skip it here, but please feel free to read it afterwards. And what is iPANEL about? It's research that is informed by and informs clinical practice. That's one distinctive feature of iPANEL, that it's a collaboration at the ground level with the nursing staff, with the people who are working on the floor, who are working in particular care settings, and the researcher doing this research together to better understand how to apply and what type of palliative approaches we need. I said my very long title, I'm not going to repeat it, but I want to acknowledge the people that have helped me very much with my thesis. First one is, two of them are members of the iPANEL, and they are Dr. Rick Sawatsky from Trinity Western and Dr. Barbara Pessett from UBC. And one additional person who helped me, who was my second reader, was Dr. Jean-François Desbiens from Laval University, and he's the one who developed the instrument that was used for the survey that was given across, actually, British Columbia. And not least, the iPANEL members, because I have been a member of the iPANEL group as a graduate student, and I received a lot of encouragement and feedback on how I should structure my work. So this is my payback to iPANEL in a very small form. The outline, as I said, I'll be spending some time on the background to why did I do this thesis, apart from wanting to graduate. What are the major concepts and what were my research questions? I'll focus a bit on the method and then the findings and discussions and what are the implications for nursing. What I would also like to invite those who are listening is to start thinking when you will see some of the results, what would you be thinking? What conclusions would you be drawing from what you hear? What else, kind of getting some collective knowledge from all of us, not just necessarily what I came up with in my thesis. So, why this study? Well, we know that the population is aging and more people are living with frailty for a longer period of time. Relatively few people will receive specialized palliative care services in particular when you are thinking of northern areas. As I said, most people who are living for longer times, they are living and dying in hospital or residential care settings. People have a variety of complexities that creates also some sort of an urgency to increase the capacity for end-of-life nursing away from the hospital and residential care, and potentially include more of the home care nursing. So eventually, nurses who work outside of palliative care, including those in hospitals and residential care, will progressively face the need to address end-of-life issues of the frail patients with multiple comorbidities. So even now in the current system, we talk primarily about palliative services. With the demographics that we are experiencing, more and more nursing staff will be spending more and more time with people who are living for longer with these chronic conditions. Addressing the spiritual needs of patients with life-limiting conditions is an important facet, and people recognize that. But it's often neglected. Even though we speak about holistic care, we don't necessarily always address the spiritual needs. What we know is that we will all proclaim that spirituality may be something that will help people with chronic conditions accept their illness. It will help them to cope with dying, but at the same time, we don't necessarily apply it into practice. And there are various factors and reasons why not. So I don't want to sound like someone who is telling people are not doing a good job. Due to the date when I did my studies, and there were no known studies that analyze the self-perceived level of competence of rural nurses and care aides in responding to the spiritual needs of patients. In the settings, I looked at 3 particular settings. It was home and community care, residential care, and medical settings. So what I wanted to do with my study is actually address this gap in knowledge. So my major concepts, I looked at, as you've seen from my very long title, I said I will break it down in some more smaller units. One of them was a palliative approach. The other one was self-perceived competence and what that means, and rural nursing, because my study looked at particularly what happens when we don't have the big specialized services. And then everything is encompassed with the lens of spirituality, because of the survey, there were probably about 20 pages of the survey. There were about 10 dimensions that we looked at, and one of those 10 dimensions was spirituality. So that's why you see this is encompassing everything in my presentation. Okay, so a palliative approach. I'm going to start with the palliative approach to rural nursing, self-perceived competency, and spirituality. So what we know, as I said, there is an increase of prevalence of chronic conditions, and I'm just going to read out some stats because they are staggering when you look at them. We know between 2010 and 2013, the BC population is projected to increase by approximately 36%. The percentage of people over 65 is expected to increase from 15 to 23.7%. And the median population age will increase from 40 to 45. And this is just in 25 years. We are even closer now. The advantages of having medical treatments and technology increases the longevity, but it also changes the pattern of disease. So now people are not necessarily dying of cancer, but most people are tending to die as a result of a chronic disease. By the time of death, most people will have developed and live with more than one chronic condition, not for a year, not for a short time, but for an extended period of time. When they live with more chronic conditions, the likelihood of them to spend their final days in a healthcare facility is increasing. And what we know, it's about 39% of all deaths are in residential care, and an average length of stay in such facilities, 835 days. Many people suffer also from slow deteriorating conditions such as dementia, and approximately 500,000 Canadians who are living with dementia right now, and this number is meant to double within the next 30 years. In BC, only about 20% of the people with life-limiting conditions are being identified with a terminal phase to their disease and placed on a palliative care plan. So we are missing 80% of the people in providing some sort of care that addresses their needs at the end of life. Because of the lack of identification of a terminal phase, as I said, the vast majority of patients will continue living with a vulnerable fragility in this indistinctive phase of being sick enough to die, but without receiving services aimed at alleviating their suffering. And that has been the work of Lynn, who started this movement towards a palliative approach to care. So clearly, the demographic predictions raise the issue of needing forms of intervention that simultaneously manage the treatment for symptoms related to exacerbation of chronic conditions and the quality of life of people with life-limiting conditions. What we know, and I probably am preaching to some of the converted, because often people, when they hear palliative approach, they think palliative care. So people are familiar with the BC healthcare system. So what we know up to now, the emphasis in the BC healthcare system was oriented towards episodic clinical care with an emphasis on treatment and management of a single disease at a time. So for instance, a person develops diabetes. You will go and see your family physician, a specialist for the diabetes. You develop a chronic renal condition, you will go and see another specialist for the chronic renal condition. And somewhere in between, this person gets shuffled in our system, and they transition through these segmented services that are all focused on treating or reducing the effects of the disease. When it comes to healthcare providers, as a person is journeying through this life with chronic conditions, most of the healthcare providers will view the discussions related to choices about the quality of living with increased frailty as part of the specialized work of palliative care teams. So we'll be thinking at some point this person will become palliative, and then that team will be having these conversations. The Ministry of Health, with their definition, obviously is assisting in promoting this worldview, because palliative care has a specific definition, and patients who go on that program have to meet those specific parameters. Now, a palliative approach, if you don't know yet, is a way of caring concomitantly for the needs for comfort while providing treatment to a person with life-limiting conditions. This approach can currently address active treatment issues and measures of comfort with a view of increasing the quality of living. It's an upstream intervention and is not limited to the prediction of life expectancy and is not reserved for specialty nursing teams. So if I can leave this conversation with one definition, is to keep in mind a palliative approach. It has nothing to do with specialty nursing, and it doesn't have to do with how long a person has got to live. But it incorporates this conversation about patient and family's needs and wishes, comfort measures, psychological and spiritual issues, discussions about death and care after death at every point of the care, to a greater or smaller measure, depending where the patient is in this journey. When it comes to nurses in the rural areas in particular, there is a lack of specialty care, so there is this real tension between this is the idea that we want to have with all these palliative care teams, and then there is the indistinctive area of the palliative approach, and how do we do it? Like, what do we need to get this going? So what we know is that rural communities have, and I'm moving now to my second part, like rural nursing, they face some unique challenges. Some of them are structural. I live in the north myself. I live in Fort St. John, and the distances between healthcare settings are quite great. The harsh weather is another factor. There isn't adequate public transportation, so if people cannot drive themselves, there is no way for them to come to services. The specialized services are not here, or if they exist, there are some barriers for people to accessing them, in particular in a timely manner. There is also a mentality that people in the north have developed, and that is rural people tend to have this, but in particular in the north, people perceive themselves more self-sufficient and independent, and they only access healthcare as a last resort for illness. When it comes to the social determinants of health, low education levels usually lead to a lack of health literacy skills, unemployment. So rural areas people in rural areas tend to make less than people in urban areas. Now, there is a caveat. There are some economically rich areas, and I happen to live in one, but that is not the general perception. About 20% of Canadians live in rural areas, and what we also know is that rural communities are aging faster than urban centers in terms of their population. Also, more people are now choosing the north to live here until they die. Typically, when they are close to retirement, people would be considering more southern areas, but that is not happening as a trend nowadays as much as it used to. As I said, geographical factors prohibit access to major centers, but also for nursing, it's in particularly very hard. It's a very difficult profession. Any ideas why? If you live in the north in a small community, what do people have in common? Dr. Patsut wrote about it, and people in the north, they have to have different expectations of what a good death means. People share some sort of accountability to their community members, and there is a moral dimension that's added to the responsibility of nurses to provide high-quality end-of-life care. At the same time, nurses work isolated, travel in isolated places, and they have limited education opportunities. And when they do, they can't attend because there isn't someone else to step in and do their work. Also, there is less access to multi-professional teams because usually it's one or two people working in a department, and people don't have access to chaplains, and then you have someone, a psychologist, and you have more groups of professionals like you would have in a larger center. So what is spiritual care? So the care of people, when it comes to spirituality, varies in terms of the stage of their condition. When a person is diagnosed with a life-limiting condition, overwhelmingly there is a focus on the physical needs. Now, as a person transitions to the end-of-life care, there is more and more recognition that this person has some emotional needs and some spiritual needs. Especially when it comes to the very last days or the end of life, people are looking sometimes for answers that are beyond the clinical prognosis or the indicators or what will the test say. They already have come to a resolution, or they are in the process to know we are in the process of dying, and now they are looking for more meaning that is attached to their illness. I will pause here because my main subject is on spirituality, as I said. So there is a revived interest in nursing. When I did my literature review, I found out that when I combine all of the major concepts into one, I found 3 studies that actually looked in particular at my major concepts, and 3 of them looked at what is the education that is needed for undergraduate and postgraduate nurses on death and dying. And the other 2 studies were specific to addressing death and dying concerns for specific population. One was looking at an Australian Sudanese community, and the other one was looking at people with learning disabilities. There were no studies that were incorporating the self-perceived competence with rural nursing, palliative approach, and spirituality. What I found out in terms of spirituality, there is quite a gray area in understanding what spirituality means in nursing. So what I did is, I don't know if you are familiar, but there is a position paper from the Canadian Nurses Association, and it gives a definition of what spirituality may be, and you can read it. And also, it gives some sort of explanation as to how else can you look at this, because it's such a vast concept, and often nurses are saying, I don't even know what spirituality means, and what spirituality means to me doesn't necessarily mean the same thing for someone else. And I hyperlinked the position paper, but I don't know if it's going to work in this presentation. So if not, I invite you to Google it, and it's about a 2-page document. So I'll go back because I wanted you to know that position paper exists. The way I divide it is a lot of people will say that everyone has kind of a spiritual dimension to their being. But there are authors like Paley, and if you read more on this subject, he's quite clear saying, no, not everybody has such a dimension, and we shouldn't be promoting spirituality if people are not willing to discuss this. Even though nurses and caregivers it's very important for us to have a fundamental understanding of what are some common approaches. So I talked about the Canadian Nurses Association uses this concept of holistic care and saying that the spiritual needs are one of many, such as physical needs, emotional needs, and that nurses have a responsibility to address them. In general, holism is closely linked to that idea of existentialism, and if any of you have read any works by Viktor Frankl, Man's Search for Meaning, that's kind of where this concept is stemming from. Another one, when you look in the literature, is how is it applied? So they will talk about spirituality in terms of health and illness, so you talk about spiritual health, talks about everyday spirituality and what people do in terms of its application. They talk about crisis spirituality, they talk about spiritual distress, distorted spiritual functioning. And when you start talking about application, you'll be also looking at what intervention do I need to do in order to respond to a need, if it's crisis or distress or spiritual distorted functioning. Also, very often you will read conversations about spirituality in relation to religion. And religion is defined as something more set with a set of rules that is it's an institutional belief, it's a ritual, and it's almost like a subset in the culture, and it's more easily followed, or it fits into a frame, while spirituality is often described as something that is more vague, that it's grounded in a person's own views of the world, and it often differs from one person to the other. And that's kind of more the postmodern worldview that says there are multiple truths, multiple spiritual truths, and every individual is the one who creates this interpretation for themselves, and it doesn't necessarily apply to someone else. Because there are so many facets, it makes it quite difficult for nurses to relate to all of this. So what the position paper and what I have been reading and the recommendations is, in order to be effective, nurses need to reflect on their own spiritual understandings, how their own spiritual perception influence their practice, and then when they do this, they need to evaluate their competence. And that is why this particular tool about self-perceived competence is relevant. Because what happens, I'm talking about the concept of competence, which is how good am I to do a particular task at any given time. But when it comes to my self-perceived competence, is based on Bandura's theory of self-efficacy, which maybe someone thinks that I am very good and I passed the test, but I really don't see myself apt to doing this particular task. As a consequence, I will be avoiding this task, or I will not be applying it every time that it was needed if I could supplement with something else. So in that sense, it's different than competence. When it comes to spiritual care competencies, there are a few authors that describe some sets of nursing competencies. And if you want to Google, I can send you all of those links to those authors. But certain names are quite well known. So you will read about Van Leeuwen and Kasveller and Baldacchino as you go through a literature search. Sometimes nurses grapple with the complexity of definition, but also they report lacking the technical skills. And what I've read is usually nurses do not get much preparation in their undergraduate school when it comes to spiritual care competencies. Also, after graduation, spiritual care competencies are not very high on a clinical nurse educator's radar when you have ACLS training, when you have particular medical areas training, spirituality doesn't necessarily meet that high standard of we need to do it right away. I took most of the time, as I said, to talk on the literature review, so to give you some sort of a background as to where my study fits in. Because, as I said, there is quite a gap in the literature, and most of the literature is polarized when it comes to spiritual care, to palliative and cancer care, and it's also looking at the patient and what are their spiritual needs, and less likely to look at how do nurses perceive themselves being able to provide for those needs. So as I said, my study looked at nurses, care aides, community healthcare workers, and the factors which promoted or inhibited the levels of self-perceived competence in addressing the spiritual needs in these three settings. This was my first research question. I wanted to know what is the level of self-perceived competence of these three groups in these three particular care settings. And the second one, I wanted to see to what extent are these differences explained by particular factors such as professional role, where they work, who they are, what they trained in, what do they know about spirituality, and how many patients do they care for. The method, it was a secondary analysis. I think I mentioned that. So I used the data from iPANEL, and I assisted in collecting the data for Northern Health. So I was a student intern with iPANEL, and I went over to almost all of the sites. And I used descriptive statistics ANOVA for my first question, and multivariate linear regression, hierarchical type for the second one, and I obtained ethics. So the primary study, it was a study that collected data from all 5 health authorities, and what we did is it was what they call a multi-stage clustered sampling. So we had a sampling model that included small, medium, and large units, and based on that, it was stratified by the size and the type of setting. So we looked at home care, residential care, and med-surg settings, so non-palliative care settings. It included all of the RNs, LPNs, care aides, or community health workers, depending on your location of work. And we took that data from the nursing nomenclature. Everybody, whether they work part-time, whether they work full-time, whether they were casual, they were all given an invitation to attend into the survey. We had 4 formats: online, on paper, in person with clinical intern, or by phone. So the survey, we took 2 phases for the survey. One of them was in 2011, and the other one was May to September 2012. In total, we had about 1,468 nurses and care aides in 114 settings, 39 medical, 38 residential, and 37 home care. And about 20% of the questionnaire were returned. So that was the total sample. Now for Northern Health, this is who we had in our sample. We had 6 home and community care settings, 7 medical units, 7 residential, and you can see mostly RNs, and then followed by care aides and a few licensed practical nurses. For those who are interested in research, I will just say that I examined the magnitude of the effect for a full sample, and it was okay. The data showed that I can follow up with my studies. So the primary measure, as I said, was a self-perceived competence on addressing the spiritual needs, and here is the instrument. So it's about 50 items. They look at physical needs, functional status, spiritual needs, ethical and legal issues, interprofessional collaboration and communication, anything that's related to personal and professional issues in nursing care, and the last hours of life. I looked at the spiritual needs, and the spiritual needs itself has 5 questions in it. So the first one, second one, third, and you can read each of them because I'll come back. The concepts were related, and I looked at the construct validity and the internal consistency and reliability using the Cronbach alpha N. You can see it was quite high. And also I looked at, I did a factor analysis, so I made sure that the scale is unidimensional and I had good values for that as well. So my independent variables were demographic, and that included the type of care setting, what type of professional background they have, how long have they worked in nursing, age, gender, where were they born, in Canada or somewhere else, did they speak English as a primary language or something else. So those, the demographic variables, they were usually categorical. So if they were born in Canada, we actually asked where were people born, but for my study, I just said other, because I would only have one individual born maybe in Germany or in the Philippines. So to make sense of the data on a smaller sample, I combined it. Same for English and other language, but for the greater study, you can look into it and you can narrow down if that's an interest. The adequacy of knowledge and education, I looked at it again and I combined this variable into more education and less education. It's a scale from 0 to 5. Responses were on a Likert scale. So anyone who was 0, 1, or 2, 0 and 1 were inadequate, 2 was adequate, and 3 or 4 more than adequate. So I just tried to combine the answers again to make more sense of the data. By doing that, of course, I lost some of the sensitivity of the data, but hopefully my study still makes sense. The work environment and the autonomy subscale came from the revised nursing work index, and that is looking at what is the support that nurses receive in work from their supervisors, how much control nursing has over their own practice, can they make decisions. It's five questions that they ask to make that autonomy scale. The findings, here comes. I use descriptive statistics and demographic distribution. So what you see here, most of the care rates work in residential, not surprising. There are no LPNs working in home and community care in our sample, but most of them, about a quarter, works in residential care, and most of the RNs work, about half of the sample work in the hospitals. In terms of age, the older staff are in home care, and the mean age is 49. They tend to be more experienced, and about 40% of them, you will see this in the next one, about 40% of them have practiced between 8 and 15 years. In general, the care rates have an oldest mean age of 46, and the LPNs are the younger at 38, born 43. In terms of experience, the residential care workers tend to have the highest group of those who have less than 3 years experience. In terms of demographic factors, not surprisingly, most of the participants were female. They were born in Canada, and their first language was English. RNs, as I said, are the most experienced, and they cumulative experience of over 8 years, and almost 2/3 of the RNs had a diploma, not a bachelor's in science of nursing, and that has to do sometimes with the age of the group. And then about 54% of the LPNs had over 8 years, and less of the care aides who had more than 8 years, about 42.4%. Autonomy in practice, that is that variable that I presented to you, I looked, and not surprisingly again, the highest level of autonomy in practice is in home and community care, and the lowest is in the hospital. The RNs have the highest level, and then the care aides have the lowest level of autonomy. Now this is a dense graph, and you can't read it, so I can decipher it to you. But I want to draw your attention to this last graph here, because I looked at this to determine the frequencies of the provider's responses on each of the individual items on the spiritual scale, and these were the 5 questions on the spiritual scale from 0 to 5 on answers. So what you are seeing, so here is 0 and here is 5, and this shows you the frequency of responses to this particular question between all of the care providers, so RNs, LPNs, and care aides, responses to assisting a person's life-limiting condition to explore the meaning of their illness experience. As you can see, 0, where it says not at all, we don't know, we don't feel at all competent to do this, it's the highest, it's about 10% here, unlike these other ones. And also the number or the frequency of the responses for those who feel, oh, I'm highly capable, it's the lowest. And that's quite interesting because, as I said, one of the main definitions, it says even in the Canadian Nurses Association position statement, says, look and assist patients to explore the meaning of their illness experience. Nurses, care aides, and LPNs didn't have so much difficulties in assessing for the spiritual needs or recognizing spiritual distress. But as I said, very interestingly, assisting to explore the meaning, that almost felt like it's a more difficult competence for them to hold. So my first research question looked again at what is the level of self-perceived competency, and what you see here is that care aides actually tend to have a higher level of self-perceived competency than LPNs. And the care aides in the home, they have actually a higher level of competency in residential care. That's not surprising because probably some of the care aides in residential care, they provide more of the daily needs than probably an LPN in a hospital or somewhere else would for a patient who is dying when it comes to the spiritual needs. But the higher level, as I said, was, here it is, there were the RNs in the home and community care. And most people felt adequately capable and least competent, as I said, and it was about 12% variation that was explained by my two factors that I included here, the type of care provider and care setting. This is the second question, my research question, and it's looking at a hierarchical multivariate linear regression model. And what I did, I looked at the concept and how are these logically related. So and then I included in 3 steps into the regression these various factors to see how much each group contribute to explaining the variability. So the first one, I looked at anything to do with education, whether it's how much nurses, LPNs, and care aides consider that they have knowledge and education on spiritual needs, what their level of education and years of nursing practice. The second one looked more of who are these people? How do they look like? And the third one looked at what's happening in their workplace in terms of autonomy, what type of patients do they look after. So I excluded gender because it was overwhelmingly female. So what it's showing is that, but what it's showing is about 58% of the variance is explained by these factors. And also what it shows is that the most variance was accounted for by the adequacy of knowledge and education. So I cannot emphasize how important that felt in terms of how competent people feel was related to how much do they think they know and they received education on this subject. The level of nursing contributed to about 17%, and the age and language and the other demographic factors only about 7%. But there were some unexpected findings, and one of them that surprised me is that the proportion of persons with life-limiting conditions was not a significant factor. I thought that would make a difference. If you have if you perceive that on your unit where you work, there are a lot of people who require, who have life-limiting conditions and require a palliative approach, you would have more of a variance based on that, but it wasn't. And also being older was negatively correlated to my findings. And in other studies, they found that RNs with diploma who are older, they tend to be more spiritually aware. So maybe that was a bit of a surprise finding, that the younger you were, you tended to be more spiritually aware. So overall, the result is the 22 independent variables explain about 2/3 of this combined variable spirituality, as I said, those 5 items in the subpopulation of Northern Health Authority, and the adequacy of knowledge and education were the most significant predictors. So what does that mean for us? Well, what it means is I looked at implications at different levels. So I looked at an individual level, what do these results mean? So one of the things that we can look at is because the levels of knowledge and education increase the level of self-perceived competence, I'm thinking, what if we use this particular instrument that was a survey instrument, what if we use it as an ongoing teaching instrument where nurses, care aides, and LPNs can apply and look at the baseline and then look at factors that even reading those questions, reading those 5 items on each of those 10 dimensions, see what area do I want to improve on and prepare an individual learning plan on that. So it can be considered a tool for continuous self-assessment. The other one was at the unit level. What can a unit do? Home care had the highest level of self-perceived competence, so maybe look at some role models from some RNs in home and community care. What are they doing differently that they are having these higher levels? And then assist the clinical nurse educators to look at spirituality as an important factor for the patient's well-being. If we consider it from all of the pressures that nursing has on the unit, especially when you work in very busy places, spirituality doesn't seem to make the list. However, from a patient's perspective, if we think of patient-centered care, this may be the one factor that can make more of a difference than how much morphine a patient may be getting at a certain time. It's one of the recommendations that educational models have to give some space and time also for increasing the awareness for education on spiritual needs in acute care. At an organizational level, I think leadership plays a very important role. And looking at every leader is looking at improving the quality of care on their unit or in their particular setting. And what I found very interesting in reading the literature is that spiritual care and addressing the spiritual need is often linked to quality care. So patients looking back or family members looking back whose needs were met on a spiritual level, they will be speaking more highly of receiving quality care than those whose needs weren't met or addressed. So for the leaders, that's good news because they can emphasize one area and get better results. And in general, I think also to the leaders is to look at how can we improve the community connections, especially in the rural areas, and look at some other stakeholders. And in some area is very well done because they hired chaplains, but it's not everywhere, so that it doesn't all fall just on one particular group of providers.
Ibolya, I actually had a question about this. It's Kara. In several of the other iPANEL studies, what they're calling for is a culture shift.
Yes.
Is that sort of what you're getting at, a culture shift on in the various settings, acute care, residential, home care, about how the practice is done?
Absolutely. So if you start, I think I alluded to that in the very beginning when I said, here is this wave of a different type of care needs that is going to come to our door. Who's going to provide for that? So that is one culture shift. And that is looking at using a palliative approach to care. There is a different wave that is happening in that, like a subculture, and saying, what is a palliative approach? Includes aspects of the quality of life factors, which are often unaddressed, and spirituality is one of those. So then there is also that change where if we continue to focus on the medical and the technology, our education budgets, our educational time, everything that's set on the unit in terms of how efficient and effective you are in your job, it's not going to give you any higher scores because you address the spiritual needs. And the spiritual needs require time because it's a relationship. It doesn't necessarily have to be a long, drawn care plan. Sometimes it's often one question in which you are alleviating that distress by asking, are you at peace?
Mm-hmm.
So I want to emphasize it doesn't have to be very complicated and complex, but it can be. So that's why in that sense, yes, it is a cultural shift because now you are including one more dimension in your care plan that someone needs to address it.
Yeah, and I was wondering also if sometimes what they're trying to get at is looking upstream in the illness trajectory to and you know not necessarily advanced care planning, but you know planning ahead to making sure. So I wonder if spirituality, if that's a little bit of a different situation because maybe practitioners don't see it as any of their business.
Yeah, good point. And that's what I've said, that initially when a person gets identified with a life-limiting condition, everything is about treatment. People are not ready to hear, what do I have to do to be at peace with this? It's anything but that. It's what do I have to do actively to get better or to contain this condition or to optimize my level of functioning. And spirituality and these needs for finding meaning tend to be addressed more later in life, unless, and I mean this, just as I said in those definitions, unless it's a part of a daily living for someone, because that's when you see spirituality as a way of life. So, and that has implications on nursing, because if a person is used to be praying every day, whether they are feeling 10 out of 10 or they are very sick and they are close to dying, that is part of who they are, and that needs to be addressed, because otherwise a fundamental need of theirs is being denied. Am I making sense?
Yes.
So depending also on the person. So part of it is looking at people who are not necessarily spiritually, they are not defined by a religion or by spirituality in everyday life, and now they are faced with a life-limiting condition or a life-threatening condition, and having to face their existential questions. And the other one is people who have lived a certain way and they want to continue with spirituality wherever they may be, whether they are in acute care, residential care, or in their homes, and optimize that.
Great, thank you.
So I talked a bit about the implication to nursing. Here are my limitations. So one of my biggest limitations was I didn't know who the providers were. This survey wasn't written to address spiritual needs alone. It looked at self-perceived competencies on a palliative approach. So we didn't know what the providers are seeing as their own spirituality. And we know that is a huge factor in determining if these needs will be addressed or not. Because providers who are more spiritually aware, they will be more aware in addressing those needs with the patients. So I would love to do some interviews about their spiritual understanding, and at some point I contemplated doing this, but then my thesis was getting a bit too long and I would have risked not to finish. And then also just understand better the demographic factors. So my recommendations would be, first of all, look at what is the scope of practice for the care aides when it comes to addressing the spiritual needs of patients. Care aides are there to observe, but especially in residential care or sometimes even in the home, they are the people who spend most of the time alongside the patient, and they are the ones who probably develop most consistent and longitudinal relationships. So if we could extend it and see how can we incorporate more in their role if they have the time. Whole discussion on competencies and looking at how to promote a palliative approach. And maybe even have part of the nurse's annual review. If you have a group of patients that fall into this category of people who are sick enough to die, but they are living in this gray zone, they're not sick to die right away, but they could. So then look at what type of competencies would this person need to develop so that we can have this more upstream approach. And then, of course, enlist managerial support. And time is one of the biggest barriers. Education is the next one. And then strengthen the patient's perspective on addressing the spiritual needs. That's what I want to say there. Because often managers listen to what the patients have to say. So the more we encourage the patients to bring this subject up, the more likely is that these discussions will come to the manager's table. And also, I would have added now with what we talk, we live in a multicultural society, so even increasing this cultural awareness as to how do I address spiritual needs in such a multi-faith environment in which we work, and what are some of those fundamentals, what are some of those terms that are common. And I gave you one example, such as the word peace. Any culture will understand, are you at peace? And it doesn't necessarily mean a particular set of beliefs or rules. My conclusion is that people have multiple opportunities to interact with healthcare providers in their journey when they are living with life-limiting conditions. RN, LPNs, and care aides in non-palliative care environments, I believe, are in a unique position to address the holistic needs, and especially when it comes to rural settings, because we tend to have more, as I said, less segmented services and also more longitudinal services, because there isn't a specialized palliative care team that you'll be going to. It's the same home care nurse, for instance, who will look after you. And sometimes the same home care nurse works shifts in eMERGE or on med-surg. The most significant predictor for increasing levels of self-perceived competence is the level of knowledge and education. So increasing the level of knowledge and education on addressing spiritual needs may improve the quality and experience of care for the patients that we care for when they have life-limiting condition and their families. If you want to know more, by all means, contact the iPANEL members. They will be able to tell you more on the palliative approach